But today, Dr. Jonathan Overcash, is going to come and talk to us about simple procedures can lead to better outcomes. How many would admit that sometimes there's just something simple you need done, but you put that off? Anybody done that? Yeah, I can think of a few. Can you? Oh, there's that lump, but it's okay, and you ignore it, or you get worried about something, but it seems really insignificant, so you don't want to go see the doctor, or you're just afraid that they might take it off in the office, and you don't want to do that, or you don't want to go through that prep work that you have to sometime when you need to have tests. But guys, hear me today, that sometimes those simple things, those simple procedures, those simple things that we like to ignore can be deadly, honestly. But let's think of it like this. If we go and we haven't seen about, it can always and usually lead to better outcomes. So with that, I encourage you to think about those things that you personally have going on, that you just need to get checked out. Get it checked out, because you know what that leads to? A peace of mind. And the older I get, I have realized that peace of mind may be the best gift of all. So think about that, and we encourage you to pick up the phone and call us. With that, I'd like to introduce Dr. Overcash and ask him to come and spend a few minutes, first of all, introducing himself so you know a little bit about him. I feel like we recruited a hometown guy because he's from Georgia. And other than the fact he pulls for the Bulldogs, and we don't, he's pretty much ours. He's like us, and we're so glad to have him. And we're so glad that even though he pulls for those Bulldogs, the great thing is that he's chosen Alabama, but more importantly, that he's chosen Sylacauga and Coosa Valley Medical Center to come and help to meet the needs of our patients. So with that, will y'all help me welcome Dr. Jonathan Overcash, General Surgeon.
Thank you, Vanessa. Can everybody hear me? I assume the mic's working. I'm Dr. Jonathan Overcash. Like Vanessa said, I'm born and raised in Georgia, and we'll kind of talk about some of this, but I was finishing up residency in general surgery and was looking for places to come, and heard about this little gym in Sylacauga, and got out my map and looked up and figured out where Sylacauga was, and was like, yeah, that sounds great. I got a chance to talk with Miss Vanessa and Mr. Sisk on the phone, and just had a wonderful conversation with them, and they got me really excited about coming here. And when my wife and I came here and interviewed, it felt like home. And we're just so happy to be here, and thank all y'all for making it so welcoming. Like I said, I was born in Atlanta, Georgia. I'm the youngest of 6 kids. I got 4 older sisters and 1 older brother. And my parents have been together. We celebrated their 60th anniversary the weekend before I moved here. So this is us at the Braves game. We took up a whole section, it felt like. So I should have updated this because I made this PowerPoint, and then this weekend I had a great nephew born. So I have 28 nephews and nieces with 2 on the way. So Christmases are pretty big at our house, but it's been a real blessing having a big family, and most of them are still here in the Southeast, so we love getting together. So that's me. I haven't changed much, obviously. Still got the same haircut. And these are my older sisters and my older brother. And then over on the right was 2 Christmases ago, we decided to remake that picture. And you can see I got a little bit bigger than the rest of them, but not much else has changed. I grew up playing sports. That was my great passion growing up. I played all of them when I was a little kid, but as I got bigger and bigger, I think we figured out that I was probably better at running into people than some of the finesse needed for some of the other sports. So I played defensive end and offensive guard in high school, and then I was fortunate enough to be recruited and play a little bit in college before I got hurt. And that ended my football career, but following that I got into martial arts, golf, golf seemed like a sport that I could probably play a lot longer than either martial arts or football, and I've always loved being outdoors. My dad was a Boy Scout master my whole life growing up, so I started going on camping trips when I was 2 years old, and just love being outdoors. This isn't your traditional football picture, but our coach felt like the old playing cards from the 70s when they did the action poses were the best ones, so there you go. This is pictures of me traveling. I love going out west, being in the mountains, hiking, climbing. I've hiked from one side of the Andes to the other before, anytime I can get out and be in the mountains, I'm in my place. That's my wife. I will introduce her more appropriately here coming up. But I went to Brigham Young University to play football, and I was there for 2 years. I got hurt after about 2 weeks, and so I never even got into a game. But I enjoyed skiing when I was out there and being in the mountains. But I transferred back to Georgia to be closer to home, close to family, and finished up there with a degree in business. I knew I was going into medicine, but I wanted to kind of round out my education and try and find a major that would kind of give me a broader understanding of the world. And I went to Medical College of Georgia for med school, and then I did a year in Chattanooga as an intern, and then 5 years at Atlanta Medical Center for residency in general surgery. And finished up there in June. And I'm a big UGA fan, but the good news is, if you're an Alabama fan, you don't have to hate me as much as you hate the Auburn guys. You don't have to hate me as much as you hate the Bama fans, so we'll all get along. I'm a licensed general surgeon. Coming from Atlanta, we do a lot of trauma there, so certified and very comfortable with all of that, but also do laparoscopic and endoscopic surgeries. I perform upper and lower endoscopy, and I do breast surgery and hernia surgeries. So pretty much anything we need in this community, I feel like I can, along with my partners, help take care of it. For October, they got us all pink surgery gowns, and somebody snapped a picture of me in it. So, and now to talk about my better half. I met Catherine during my residency. We actually met online. I don't know if you know much about residency, but you're pretty much working, and whenever you're not working, you're sleeping. She also works. She's a team leader for Georgia Pacific, and that keeps her very busy. So we met online. Hit it off right away. I proposed to her in Chattanooga a year later, and we got married a year after that. And we're going to be having our first anniversary here in just under 2 weeks. So she loves going to the beach. She loves traveling as well, staying active, running, doing yoga, and loves spending time with children. So hopefully be adding some of those to the family here in the next years. This picture on the left is a picture of our proposal in front of the waterfall on the cliff. Felt like I nailed it. She said yes. The sign back there says it's called Lover's Leap, and she asked me why they call it Lover's Leap. She had no idea I was going to propose to her, and I told her, oh yeah, some guy proposed to his fiance there, and she said no, so we jumped off. And she's like, oh, that's terrible. And then fortunately she said yes. And then this is our wedding on the river there in Chattanooga, and it was a beautiful ceremony. And this is our pet Nicodemus. He's my 8-foot shark that I caught on my bachelor party, and we got him mounted. He's our only pet right now, but looking forward to getting some more now that we got a yard, and that's my beautiful bride. So, but enough about me. We're going to be talking today about medical screening, and like Vanessa said, some fairly simple things that we can do to try and prevent some bigger problems. So first we'll kind of talk about what is medical screening and then why it should be important to us. So medical screening is examining a group of people who don't have symptoms and trying to find if they have the early stages of a disease that could be potentially devastating if it progressed. And you're trying to do this through means of inexpensive and less invasive testing. In order for screening to really work, the disease has to be fairly common, and it has to have a significant harm if it gets caught in later phases, but it has to be treatable if it's caught in early stages. If we screened for something that had a 100% chance of dying, there's nothing you could do about it, then it wouldn't do us a lot of good to know about it early. It'd just give you, a lot of trouble and anxiety. But if it's something like, some things we'll talk about, where if you catch it in the early stages, you can treat it pretty easily, then you can save a life. And then the test has to be fairly sensitive and cost-effective. But because these tests have to be so sensitive, sometimes they're not necessarily 100% diagnostic, and we'll talk about this. But what they do is they prompt further confirmatory testing and then treatment. So why we don't screen everything for everything, sometimes there's not a test for it. Sometimes the test would be more expensive than it's worth. These tests can be uncomfortable. There are risks with anything that we do. And so the tests that we do screen for are the ones that kind of meet these criteria that we talked about. So some of the examples of things that we screen for in medicine would be going and getting your cholesterol screened, or getting mammography or bone density scans and so forth. Things that, when you go for your checkup, your doctor may be doing some of these things and getting you set up for these, and you may not really realize why we're necessarily doing it, but it's to try and, catch these things early and treat them before they become a big problem. We're specifically in general surgery going to be talking about colonoscopies and mammograms, because I think they're so important for us, and it's something that we can help with. Yeah, so, and talking about colon cancer, it's the third leading cause of death from cancer in the United States. Kills almost 50,000 people a year, and you get about 135,000 new cases every year, so it's pretty prevalent, and it can be pretty devastating if you catch it late. And unfortunately, with this cancer, the number of cases are going up every year, and the average age of discovery is going down. So it's one of the surgeries we're kind of moving the wrong direction on. Some of the things that lead to that, age, obesity, a sedentary lifestyle, diet high in meat, low in fiber. So basically, the way a lot of us live and eat here in America kind of adds to this, and it's made it kind of grow. Also, alcohol and tobacco add to this, and then there are genetic factors as well. And so one of the screening tests we do for this is called colonoscopy, and it uses a flexible camera that goes in and allows us to look and see if the lining of the colon is normal, or if there's abnormalities like a polyp like what shows up in the middle picture. And then it also gives us the ability to test these to see if they are precancerous or cancerous or otherwise. And you can do that by using tools that actually go up through the camera, like this snare on the right. What we can do with it, we can locate abnormalities, we can biopsy or remove them. If it's something that we can't remove or something that we're worried about maybe being cancer, we can tattoo it so that we can see it later during surgery. Other things that have nothing to do with cancer, we can control bleeding with this, diagnose other diseases like Crohn's disease, and in other cases we can decompress the colon and stuff like that and other medical conditions. But what we'll really be talking about is in terms of screening colonoscopy, screening for cancer. So if you go in and you see a polyp like is at the bottom, you can go in with this snare, you can reach around it, you can remove it, And then you can take that polyp and you can look at it under a microscope, and the pathologist can look at it and tell you if it's just a kind of normal benign growth, or if it's precancer, or if it's unfortunately cancerous. And then we can do other testing and treat you, hopefully at an early stage. And this has been very effective. It's been associated with a 67% decrease in mortality from all colon and rectal cancers, compared with not doing screening colonoscopies. If we go back talking to the number of new cases we find every year, the number of people living with this, that's a huge number of lives saved by doing these screenings. As far as the recommendations, people who fall into a normal risk category, they have no symptoms, they don't have anybody in the family with colon cancer, they don't have certain genetic problems, they should start at around 45. And then should continue through the age of 75. And then between 75 and 85, you should talk to your doctor and see if you're still a good candidate for screening. What a lot of that has to do with is just based on your overall health and expectations. If you're super healthy at 85 and 85 is the new 50, then it makes sense to go ahead and keep screening. But you should start earlier if somebody in your family, a parent, a sibling, or a child has had colon cancer. You should start at 10 years earlier than the age at which they were diagnosed to start looking. And then if you have certain diseases like Crohn's disease or certain genetic things. And then also as far as how often should you have it, usually every 10 years, as long as everything's normal. If you find polyps, if the polyps are certain types that may be precancerous and so forth, then we shorten it down to sometimes 1 to 3 years. Switching gears now, we'll talk about breast cancer and mammography. Unfortunately, this is a very common cancer. About 1 in 8 women will be diagnosed with invasive breast cancer at some point in their life. 268,600 new cases of invasive and 62,900 of in situ breast cancer every year. And there's more than 3.1 million women in the U.S. alive who either have or have had breast cancer. And it kills 41,760 people a year, unfortunately. It's the most commonly diagnosed cancer in U.S. women, and it's only surpassed by lung cancer as the leading cause of cancer death in women, so big deal. There's 2 main types, ductal and lobular, and that refers to what kind of cells they come from, but they can both be very devastating if caught at later stages, and you can find it also in a non-invasive versus invasive, depending on how deeply it's penetrated by the time you find it. And then other things we look for are how differentiated it is, so whether or not it still responds to estrogen, progesterone, and so forth. And those things have to do with how we treat these. So in order to find all that out, we have to get biopsies. So first we have to know if you have a lump or an area. And the way we've done that, we'll talk about with mammograms. But, risk for breast cancer, female gender is the number 1 risk. 99% of breast cancers happen in women, with only 1% happening in men. And then the older we get, the higher our risk goes. There is a family association with this, especially with these genetic markers that can increase your risk by 72% or 69% if you have those. But 85% of women that have breast cancer are the only women in their family that have had it so far. Just not having had an aunt or a mother or a sister that had it doesn't mean that you don't need to check. The way we check is with mammograms, and what these are, they're X-ray images of the breast in 2 different angles that allow us to look for concerning calcifications and other signs that there might be a mass there. and it's between 90 to 93% sensitive. If you do it multiple years in a row, that gets up to 98% sensitive. And then if you find something abnormal on it, that doesn't necessarily 100% mean you have cancer, but it means that you need more testing. And so they usually have you come back, take more images, and then they talk to you about seeing a surgeon for maybe a biopsy. That's what we'll talk about. So these would be considered pretty normal mammograms. These would be abnormal. So you can kind of see, in the one on top with the circle, you have these weird kind of star-like spiculations, we call it. Below that are microcalcifications or little deposits of calcium. And then on the right, you've got a large calcified mass. So these are kind of things that we're looking for. But even more subtly than that, this is why we have to do this, because you may not be able to feel these if you're doing a breast exam otherwise. So it's a way of catching this earlier, getting it treated at an earlier stage where your survival is much, much better. So if you have an abnormal mammogram, they'll usually send you to talk to a doctor, and a lot of times that'll be a surgeon like me, and we'll talk about your mammogram, and we'll discuss getting a biopsy. And what the biopsy does is it lets us look at the cells and see if they're precancerous or cancerous so that we know what we need to do. And there's different ways we can do this. We can do it using stereotactic biopsy, where we use x-rays to find it. We can do it with an ultrasound, or we can do it by, if we can feel the mass, cutting it open and taking out that area and then sending it. But more and more now we're using stereotactic and ultrasound guided biopsies just because they're less invasive. When it comes to treating breast cancer, what it really has to come down to is what size is it, where is it, does it involve any of the lymph nodes, has it spread anywhere else, and then how receptive is it going to be to hormone treatment and chemotherapy and stuff. And that's what these biopsies can kind of tell us. And if we do find a cancer and we have that information, then it lets us use a real multi-team system to treat this. We treat it with radiation, chemotherapy, hormone therapy, and surgery. And that's given us really, really good improvements in life expectancy with these. Far less need for mastectomies. You can usually, a lot of times, get away with just removing the lump itself and then treating. And then also just the overall survival has really, really improved to this point. If you have a earlier stage cancer, you have a 95% chance of surviving for 5 years after that. And that's really kind of how we measure survival when we talk about cancers over 5-year periods. The key is early detection and then, getting that biopsy, because what type of cancer really affects how well you do. So we recommend that you do annual screening in any woman with normal risk starting at 40 and definitely no later than 50. And then you should continue to 75. And then at 75, it really should be a discussion between you and your doctor. And it kind of depends on if, based on your other health problems and stuff, if you expect to live 10 more years, you should keep going with screening. If you do have somebody in your family, like your mother or sisters or aunts, who have had a diagnosis, then you should start 10 years before their diagnosis, the age that their diagnosis was made. So kind of what we can do here in Sylacauga, my partners and I, we can do routine screening colonoscopies, and we can kind of be your follow-up for your routine screening mammograms. So we perform the colonoscopies here at the hospital, and then we can also perform the surgeries if we do find something, to treat it afterwards. And then also, as far as if you have abnormal mammograms, we can either do biopsies or help kind of get you set up for those. We can perform the surgeries like the lumpectomies, lymph node testing, and if necessary, mastectomies to treat the breast cancers as well. And we're happy to help. I know this can be very stressful if you do get a positive, cancer diagnosis, but it's something where, we're a big part of the team and can help, kind of treat you and get you through it. So, I want to thank you all for lending me your time and listen to me go on, and I'd be happy to answer any questions y'all may have, and look forward to working with y'all here. Yes?
What about 3D mammograms?
3D mammograms. So 3D mammograms are kind of a newer technology. We're really, it's images that are more like a CT scan, so they can kind of put them together and look at it at different layers. It has not been shown to be better than regular digital in terms of finding them with the research, but we're kind of hoping that as that technology improves, that it may be eventually. Any other questions?
I always have a mammogram, they always say we can check dense breasts. And the doctor said it requires a 6.
Yeah.
But it means that it's just not as easy to find if you have the problem, right?
Yeah, so the question was about dense breasts, and that is a good point. Dense breast tissue means that you have basically more kind of the connective tissue and less fat in the breast, which can make it harder to see on a mammogram. And so it's something where, especially in younger women, sometimes they use other things plus mammogram to look at masses and look for masses, whether that be ultrasound or MRI. But you usually still start with the mammogram and then get directed to either MRI or ultrasound as needed based on the density and the findings.
I still have one in here.
Good.
Right here.
Good.
Even as the age you recommend, I still have one.
If you're doing well, and hopefully you all are, then I would recommend keeping and doing it. I know it sounds kind of morbid to say if you don't anticipate 10 years, but that's really more for people if you have like a diagnosis otherwise that so absolutely. Any other questions?
Elaborate just a little bit about, you said you were really involved in trauma care, and I know back years ago at Silicaca Hospital when I was just out of high school and I watched surgeons take care of really, really broken up people and people that had major problems from automobile accidents and stuff. How does that work now? Would you still assist at the hospital here, or?
So the way that works now is there's a statewide trauma network. And so you have different levels of hospitals. You have level 1,